So today I'm going to give you an update on anesthesia for the cardiac patients. That means patients with underlying cardiac conditions coming for non-cardiac surgeries. I think this is one of the very important topics to be discussed because uh, as you all know, worldwide the prevalence of the non-communicable diseases are increasing, including the cardiovascular diseases. So as a result, in day-to-day practice, you come across increased number of patients with underlying cardiac conditions coming for all sorts of surgeries. So having a sort of sound knowledge on this topic is important to minimize the adverse effects affecting the cardiac patients coming for non-cardiac surgeries, and at the meantime to avoid complications and improve the outcome of those patients. So today I'm going to discuss basically why exactly it is important to be discussed, and then bit of physiology behind the mechanism of perioperative myocardial injury and infarctions, and how to estimate the perioperative risk based on the patient's underlying clinical conditions, functional capacity, and how to calculate the surgical risk. And depending on those factors, using risk scores, how to calculate the estimated cardiovascular risk, and then stepwise approach using flow charts according to the guidelines to how to approach for a patients with the cardiac condition coming for a surgery, and then guidelines based perioperative management as well. So those are the things I'm going to discuss today. So why it need to be discussed? According to the UK figures, about 1/3 of the patients coming for surgeries are having some form of underlying cardiac condition. And in United States, more than half of the patients over 45 years are having some degree of or some kind of cardiovascular risk factors. And patients with increased cardiac conditions to have increased number of adverse effects are also increasing. So unfortunately, however, we don't have figures or studies in our setup, but I think in our setup also would be the same, or maybe it is much worse in our setup. And if we get the most common cause of the death after the anesthesia or the perioperative period, it is perioperative cardiac morbidity. If somebody happens to have a cardiac complication, including a perioperative myocardial infarction, the mortality associated with the perioperative myocardial infarction is very high. It is around 40 to 70%. So it is important for us to know about this topic to minimize these complications and morbidity and mortality. So from the very beginning, I want to highlight these two guidelines. One is AHA, American Heart Association guidelines on perioperative cardiovascular management for non-cardiac surgeries. This is published during last month, September 2024. The other one is 2022 published guidelines 2 years ago, ESC guidelines on cardiovascular assessment and management of patients undergoing non-cardiac surgeries, which is endorsed by the European Society of Anesthesiology and Intensive Care as well. So these two are well established, well known to guidelines used worldwide. So I'm highlighting this because in my subsequent slides, the facts included in subsequent slides are mainly based on these two new guidelines. And how to evaluate a patient undergoing a non-cardiac surgery, a patient with underlying cardiac condition. So before everything, history comes first. So evaluate the patient's medical conditions, like if the patient is presenting for a non-cardiac surgery. So we have to ask the patient's medical history. What are the medical conditions the patient is having, and how long the patient is suffering from these medical conditions, and over time, how the medical conditions have evolved over time, whether there is any worsening of symptoms, and at the same time, what are the medications the patient is been taking. Those are the important facts in the medical history. And most importantly, apart from the medical conditions, we have to ask the patient's functional capacity. So as anesthetists, we every day when we do our pre-medications, pre-operative assessments, we assess the patient's functional capacity. So functional capacity is very important when it comes to cardiovascular patients. So functional capacity, it assesses the patient's physical fitness by the means of cardiovascular and respiratory fitness to undergo the surgical stress during the perioperative period. And depending on that, so we calculate the surgical risk as well. And there are different risk assessment tools, which I'm going to discuss soon. So with those risk assessment tools, with the history, examination, and the surgical risks, according to those, we are going to calculate the risk. And according to the risk, so we are going to formulate or we are going to perform necessary investigations for those patients. Depending on that, we are going to formulate a management plan for the perioperative period. If a patient is having a very high risk, so the management plan could include in the invasive monitoring intraoperatively, maybe post-operative ICU care, all of that. Cardiac output monitoring. So everything could be included in the perioperative plan, depending on the patient's risk and underlying conditions. And at the same time, after perioperative management, for the long-term management, we have to refer the patients for the specialized care. And along with all these processes, we should not forget the active participation of the patient and the family during the process of decision making. So we have to get during the consenting procedure, informed consent taking. So we have to inform the patient regarding the risks or especially the medical conditions patient is having and the risks associated. What is the management plan we have formulated and what are the risks associated? What are the possible complications could be developed? We have to educate everything depending on we have to tell the patient depending on the patient's understanding and the level of education as well. So don't forget with all your managements, the active participation of the patient and the family during the decision-making process. So, few words about the myocardial infarction, the mechanisms. As I think you all aware, there are three different uh, types of in a classification system, different types of myocardial infarctions. So we say, if you can see in this diagram, so we say type 1 myocardial infarction, that is classical myocardial infarction, where there is atherothrombotic disease. So where there is a kind of in the coronary arteries, there is atherosclerotic disease, unstable plaque, then the plaque rupture, resulting in platelet aggregation and thrombus formation, resulting obstruction of the coronary vessels, and beyond the obstruction, there is reduction in the blood flow. So there is myocardial injury, ischemia, and ultimately myocardial infarction and death. Then comes the type 2 mechanism. As you can see, it is where the supply-demand imbalance comes. This is very important type 2 mechanism resulting type 2 myocardial infarctions because studies have found out more than 70% of the myocardial infarctions happening in the perioperative period are mostly due to or attributed to these type 2 mechanisms. In the non-operating setup, majority of the infarctions are this classical type 1 ischemia and infarctions, but in the perioperative setup, majority of infarctions, more than 70%, are due to type 2 mechanisms. So supply-demand mismatch. For an example, in a patient, if there is like hypotension during anesthesia, intraoperative period, or during the perioperative, pre-op, intra, post-op, if there is hypotension, so there could be reduction in the coronary vascular flow. And if there is tachycardia, if there is tachycardia, there is always increased demand. So there is supply-demand imbalance comes. And then if there's like anemia or hypoxia, low saturation, there could be reduction in the oxygen delivery to myocardial tissue. This could result in supply-demand imbalance, resulting in myocardial injury, myocardial ischemia, and myocardial infarctions as well. So that is the importance of knowing these mechanisms. So we have to keep in mind during the perioperative setup to manage the hemodynamics smoothly to avoid this supply-demand imbalance. And then estimating the perioperative risk. So as I described earlier as well, the clinical assessment, functional capacity, and the surgical risk assessment, and then the classification systems comes. What is this perioperative risk? What is the risk we are talking about? So the perioperative risk means if a cardiac patient, the patient with underlying cardiac conditions coming for a non-cardiac surgery, so the patient is already having some sort of cardiac impairment. If this patient is going to undergo a surgery, so the risk means the risk of developing perioperative major adverse cardiac events. In short form, we say MACE, major adverse cardiac events in the perioperative period. So the major adverse cardiac events could be the myocardial infarction, it could be myocardial death, or else it could be a myocardial infarction requiring immediate coronary revascularization interventions, or it could be a stroke as well. Those are called perioperative major adverse cardiac events. The risk is the risk of development of the MACE, major adverse cardiac events. So in the clinical history, so what are the conditions in the history, in the medical background, what are the conditions associated with major risk of developing these MACE, major adverse cardiac events? There are four major factors which are considered as major risk factors for the development of MACE. That includes unstable coronary syndromes and decompensated heart failure if the patient is having significant arrhythmias or severe valvular disease. Under unstable coronary syndromes, if the patient is having severe angina, unstable angina or severe angina, plus recent myocardial infarction. Recent means less than 30 days. What is the recommendation? According to the recent evidence, the recommendation to delay the elective surgery after a recent myocardial infarction, it is recommended to delay for 4 to 6 weeks if feasible, especially if an elective surgery is planned. So if a patient with a recent MI less than 4 to 6 weeks, if a patient comes within this period of time, so this patient, if this patient is facing or going to undergo a surgery, so you have to keep in mind this patient in compared to a normal individual or established other coronary syndrome, this patient is having additional risk of development of MACE. Apart from that, decompensated heart failure and significant arrhythmias, including heart blocks, bradyarrhythmias, trachearrhythmias, those sort of cardiac arrhythmias are again carrying a higher risk of developing MACE in the perioperative period. Valvular disease, especially if the patient is having a valvular disease who is symptomatic, like symptomatic mitral symptomatic valve stenosis or symptomatic valve regurgitations, having increased risk of MACE. Those are the four main conditions in the medical history. So we can get that these patients at a higher risk of developing MACE. So what are the intermediate risk factors? These are the conditions that include the intermediate risk factors are the patients who are having established ischemic heart disease and history of compensated or previous heart failure, cerebrovascular diseases including strokes and TIAs, and diabetes mellitus, especially insulin-treated diabetes mellitus, if the patient is having renal insufficiency. Those are categorized as intermediate risk factors. And minor factors wise, elderly people, patients are having some ECG abnormalities, STO T-wave changes, rhythm abnormalities like chronic AF, and uncontrolled systemic hypertension. Those are coming as minor risk factors for the development of MACE. And most importantly, I highlight the importance of assessment of functional capacity. We all assess the functional capacity. So functional capacity we assess depending on the physical activities the patient can do in day-to-day life. So if the functional capacity is good, so we say that the patient is having a reasonable amount of physical strength or the fitness to undergo a major risk or intermediate risk surgery. So here, so we can assess the functional capacity by using the MET score, or else you can use the Duke's activity status index. In both of these, so we assess the patient's physical activities the patient can do, and depending on that, we give a score. Kind of, if you use MET score, we say if the MET is more than 4, that patient is having a reasonable physical fitness. And in Duke activity status index, the same. So we give a number depending on the activities the patient can do, and we get the sum of the activities. And then if the score is more than 34, we take it as similar to MET more than 4. So either of these, like activity status index or MET score, we can use to assess the functional capacity. So I know that most of us are very, very familiar with and well aware of the MET score, so we can use either of these. So in the AHA guidelines, American Heart Association guidelines, they highlight the importance of assessment of functional capacity using a valid risk tool. So, in the ESC, European guidelines, they recommend the assessment of functional capacity by the means of self-reported ability to climb 2 flights of stairs. So, every day, again, anesthetists ask these questions irrespective of the surgery and the physical conditions patient is having, whether the patient is able to climb 2 flights of stairs. So, what is exactly meant by these 2 flights of stairs? So 2 flights of stairs is two separate sets of stairs with a break or landing in between. In many buildings, one flight of stair contains about 10 to 15 steps. So 2 flights of stairs means, so there are 20 to 30 steps. If a patient can climb these 20 to 30 steps without stopping, without hesitation, that means the patient is having a reasonable or good functional capacity that we categorize according to the MET score. The MET is more than 4. So the ability to climb these 20 to 30 steps in a one go is important. So they highlight also importance of assessment of that as a measure of assessment of functional capacity. And then surgical risk. So the surgical risk is dependent on the urgency of surgery, invasiveness of the surgery, and of course, depending on the type of the surgery as well. So uh, regarding the urgency of surgery, the American Heart Association guidelines, they give certain definitions. They categorize surgeries into 4 groups depending on the urgency: emergency surgeries, urgent surgeries, time-sensitive surgeries, and elective surgeries. So emergency surgeries, so from the decision making to the time of surgery, it is less than 6 hours. So emergency means we are doing life-threatening or life-saving or limb-saving surgeries. So there we have no or very, very limited time for the assessment of the patient and for the optimization in emergency surgeries. Urgent surgeries, we have a little bit more time than compared to emergencies, but so we should perform it within less than 24 hours from the decision making time. So it's time-sensitive procedures. It is basically oncological. Cancer surgeries comes into this category, time-sensitive surgeries. So we can wait up to 6 weeks. Elective procedures delayed up to 1 week. So that doesn't mean if there is a patient coming for a cancer surgery or an elective procedure, if the patient is having underlying cardiac condition which should be optimized, we have to wait for 6 weeks or 1 year. That doesn't mean that. So if a patient is having a cardiac condition, to be optimized. So we have to optimize the condition as soon as possible. Need to wait for 1 year. When it is optimized, we can go ahead with the surgery and do the surgery. And so, for an example, we had a patient recently. So, patient in his 60s, male patient, who is coming with a left renal cell carcinoma. Renal cell carcinoma involving the left kidney. And CT, there was evidence of capsular left renal capsular involvement plus extending or the tumor involvement of the renal vein as well. So, and this patient had a history of ischemic heart disease. He had underwent a coronary angio 6 months back before the cancer is being diagnosed. And then there was evidence of 60% obstruction of the left main coronary. So at that time, the cardiologist's opinion was because it is 60% moderate obstruction of the left main. So they advised the patient to be on the medical therapy. The patient has been taking the medications regularly, but by the time the patient presented with the cancer, so the patient was complaining of some degree of worsening of the symptoms to some extent. So we again referred the patient for the cardiology because the patient was having this worsening of the symptoms again. So at that point, because the patient is having the cancer, patient is going to undergo the cancer surgery, radical nephrectomy, and the patient is having 60% obstruction 6 months back, the evidence by the coronary angio, and some degree of worsening of patient's condition, the underlying cardiac condition. Patient was symptomatic, and we got the help from the cardiologist again. And that point, their opinion was because this is a time sensitive surgery, even though the symptoms got worsened, so their next plan of management would be repeating the coronary angio and see whether the obstruction of the coronary left main stenosis has increased or whether there is any significant obstruction. If there is any obstruction, so the next option is to do the revascularization or the percutaneous intervention, stenting the left main coronary. So nowadays, thinking of the durability of the stents and all, most of the time they use the drug-eluting stents. If a drug-eluting stent is used during this revascularization, then of course we have to wait for another 3 months before the surgery because we have to continue the dual antiplatelets for another 3 months after the drug-eluting stent placement. So what happens after the end of the 3 months? Maybe the patient's condition, the cancer maybe spread to everywhere, or patient gets a query whether the patient will survive at the end of 3 months. So the decision, again, the multidisciplinary decision was taken to go ahead with the surgery without any cardiac intervention. And we went ahead with the surgery with all the strict cardiac monitoring with the post-operative ICU care as well, and patient recovered without any cardiac damage. So likewise, depending on the individual patient, with the individual condition the patient is having, and depending on the surgical risks as well, so we have to plan the overall perioperative management. That is one of the examples. And when it comes to surgery, type of the surgery and associated cardiac risk. So again, we classify the surgeries to low risk, intermediate risk, and high risk surgeries. This is only taking into account the surgical condition without taking into account the patient's underlying medical conditions. Only the surgical intervention is taken into account. Depending on the surgical intervention, they have calculated the 30-day risk of cardiovascular death and myocardial infarction. So depending on that, so they categorize low-risk surgeries as like superficial surgeries, breast surgery, thyroid also comes as low-risk surgery, and minor gynecological, urological, orthopedic surgeries are coming under low-risk surgeries for cardiovascular complications. If you categorize or if you consider only the surgical intervention. And then intermediate gynecological or urological surgeries and renal transplants. So very high risk surgeries are when there is opening into thoracic cavity, lung resections, and when there is opening into peritoneal cavity, most of the bowel surgeries, bowel resections, liver resections, bile duct surgeries, esophagectomies, and major vascular surgeries, especially we mentioned suprainguinal vascular surgeries. So those are categorized as with considering the surgical intervention alone as very high risk surgeries to develop cardiac complications or MACE, major adverse cardiac events. And then risk scores come. So far I discussed the patient's medical history, functional capacity assessment, and the surgical risk depending on the surgical type. And when it comes to risk calculation, so at different times, this is why I have included a lot of risk calculators for your references if you are interested. So basically, one of the commonly used and risk score which is very easy to be used is Lee's revised cardiac risk index, which was introduced in 1999. So what is the importance of risk calculators? So if a patient with a cardiac condition or cardiac abnormalities with cardiac impairment coming for a surgery, if this patient is going to undergo a surgery, during the decision making, during the consenting process, we are going to tell the patient you are having very high risk of developing complication, or else you are having moderate risk, you are having low risk. Kind of, we are using vague terms. So when it comes to risk calculators, they give us a percentage of risk, quantification of the risk with a number, so we can tell the patient directly. So you are having this percentage of risk of developing these complications. Likewise, that is the importance of risk calculation during the consenting process. It is very important to educate the patients. So in the least revised cardiac risk index, there are clinical variables. So depending on if there is presence or absence of clinical variables, we give points. So first comes high risk surgery, as I mentioned earlier, where there is opening into thoracic cavity, opening into peritoneal cavity, and then where there is very high risk vascular surgeries, those are categorized as high risk surgeries. So we are going to give 1 point if the patient is going to undergo a high risk surgery. And then if there is ischemic heart disease, congestive heart failure, history of cerebrovascular disease like TIA is also included, stroke or CVA, stroke or TIA, and insulin treated diabetes mellitus. And if the serum creatinine level is high, more than 2, so we are giving 1 point for each. Depending on the number of points, then we have the risk as a percentage. If the score is 3 plus, then the risk is more than 11%. So we can tell the patient directly you are having more than 10% or 11% risk of developing MACE, major adverse cardiac events. And if the patient is having 0.01, we can say you are having less than 1% of chance of developing these major adverse cardiac events. So this is very important. When you are doing the preoperative assessment of the patients, if there is a patient with cardiovascular diseases, cardiac disease especially, so we can apply or we can calculate the risk with the least revised cardiac index, and you can include this in your preoperative assessment. Then the preoperative assessment looks more smart and more complete. So I think I hope that you will apply this in future. And then again, the European guidelines and the American guidelines, they highlight the importance of calculation of the risk, which estimate the perioperative risk of MACE. And then I'm going to discuss on, so you know that now the risk assessment, risk scores as well, and what are the recommendations to do different types of investigations. So if a cardiovascular disease patient is coming for a surgery, for each and every patient, we do a perioperative or preoperative ECG. as a baseline. And depending on the ECG findings, if there are abnormalities in the ECGs, we need to do the further evaluation. For an example, if you find to have some ECG changes, first of all, we do check the ECG changes and we assess the previous ECGs to see whether these are old changes or new changes. If there are new changes, what we are going to do is most of the time, what we do is we repeat the ECG in a couple of hours or 1 hour's time mostly and see whether there are any dynamic changes. And if there are dynamic changes, so we are having a query in the back of our mind: is this acute coronary syndrome? Then we ask the patient whether the patient is having any clinical symptoms or signs or clinical features of chest pain or acute coronary syndrome. And if there are ECG changes, at the same time, we are going to send troponin, troponin assay, depending on the availability, routine troponin assay or high sensitivity troponin. And if the patient fulfills the criteria to diagnose acute coronary syndrome, if it is an elective surgery, obviously we are going to treat for the acute coronary syndrome first. And meantime, we are going to get the cardiologist's opinion, their help to evaluate this patient further to assess the cardiovascular underlying cardiac conditions and the fitness. So then the cardiologist, depending on the patient's overall conditions, so how the cardiologist assess these patients, they take the detailed history like us, the patient's medical history, what are the other risk factors the patient is having, other cardiovascular risk factors, patient's family history, whether there are close relatives are having the same cardiac conditions likewise, and the patient's functional capacity, and they assess the frailty as well. Depending on these factors, they are having their own different risk calculation scores like Timmy score, Gray score. They use different scores to calculate the risk, which and depending on the risk, which investigations this patient needs. Maybe they do only the ventricular function assessment, left ventricle or the right ventricle assessment of the ventricles, and then they will order a stress test depending on the patient's risk. So it is the cardiologists who are going to decide on which patient needs a stress test only or which patient needs then coronary angio. Likewise, they are going to decide. And however, during the perioperative period, because we are using a lot of analgesics and sedative medications, especially post-operative period, so because of the analgesia and the sedative medications, most of the time the clinical symptoms are masked by the sedation and analgesia. So most of the time we have to take more reliance on the assessment of the cardiac troponins and the ventricular assessments, including the transthoracic echoes. So with the echo, we tend to find out whether there are any regional wall motion abnormalities. That means if there are any akinetic segment, whether there are any akinetic segment, hypokinetic segments, likewise. So we have to have a more reliance on the assessment of the cardiac biomarkers and the ventricular functions with using the transthoracic echo to find out whether the patient has developed one of the complications, major adverse cardiac events, especially cardiac adverse events. And what are the indications to do ventricular function assessment? Especially when you're examining a patient, if you find new onset of dyspnea or any physical examination findings of heart failure, so then echo is indicated assessment of the ventricular function for the assessment. And then in a patient who is established or who is already diagnosed with heart failure, if there is any worsening of symptoms since the diagnosis, then we have to perform the echo again. So, for example, there is a patient with heart failure, the echocardiography or the ventricular function assessment was done around couple of months ago. For an example, if the patient is having ejection fraction of 45%, if the symptoms are worsened, so we can perform the echocardiography again and see what is the ventricular function or the impairment now. If the ejection fraction has dropped from 45 to 15% now, so our management plan would be different. So it is important to assess the ventricular functions if there is any changes in the symptoms or worsening in the symptoms in a patient with established heart failure. And according to the European guidelines, the additional indications to a thoracic echo or the ventricular function assessment is if a patient is having poor functional capacity. There are patients coming for the surgeries where there is poor functional capacity or we can't assess the functional capacity. On those type of situations, so we can use the transthoracic echo. It is recommended. And at the same time, if there are high BNP levels, so we do not practice in our setup very often. And if there is a significant murmur detected during the clinical transthoracic echo, and if a patient is having suspected new coronary cardiovascular disease or unexplained signs and symptoms, again, we can refer the patient for the cardiologist to do a echo. The other indications I have already discussed. So those are the indications to do a transthoracic echo for a patient with cardiovascular disease coming for the non-cardiac surgery. And then stress test. As I mentioned earlier, uh, who, who are the candidates, who are the suitable patients for the stress test is decided by the cardiologist when we take their opinion regarding patients. So the stress testing, actually, when they do this stress testing, if there is reversible myocardial ischemia, that means the patient carries a higher risk during the surgical stress period, during the perioperative period, to develop MACE, major adverse cardiac events. So stress testing can be exercise stress test or pharmacological stress test, which is done, for example, dobutamine stress echo. So always exercise stress test is preferred over pharmacological test in the means of functional capacity assessment. But in patients who are unable to do the exercises, like patients with arthritic conditions, for example, so those patients are the candidates for pharmacological stress tests. So when we are talking about stress testing, we can't forget the gold standard of physical fitness assessment test, CPET, cardiopulmonary exercise testing. If the CPET is available, that is gold standard. We can, before the surgery, so we can refer the patient for the CPET. So unique feature of CPET is we can, if a patient is having some kind of functional impairment or the impairment of the functional status, we can exactly find out whether it is cardiac or the respiratory. The cause for the functional impairment, if it is cardiac or the respiratory, that could be find out with the CPET. And our goal of doing stress testing is not to identify the undiagnosed cardiovascular disease. It is to identify the patients who are suitable candidates for the revascularization prior to the surgery to have an improved outcome, especially before elective surgeries. And then comes to coronary angio. So coronary angiography, again, it is decided by the cardiologists depending on their risk scores, which patients needs coronary angio. So it could be coronary CT angiography or invasive coronary ICA means invasive coronary angiography. So again, in patients with poor functional capacity with elevated risk, so they calculate the risk according to their risk tools. So with the coronary angio, so we can get an idea about the epicardial coronary vessels and the degree of atherosclerotic coronary artery disease, including which vessels are involved and the severity, location, and everything we could assess with the coronary angiography. And then, depending on the coronary angiographic findings, they can determine the feasibility for whether this patient is a candidate for the PCI or this anatomy is suitable for PCI If it is not suitable, the patient is referred for bypass grafting, coronary grafting. So not all the patients are candidates for the revascularization, especially the patients with critical stenosis of the left main stem. And again, the patients with multiple vessel disease with impaired left ventricular functions, those are the patients. They select the patients depending on those features for the revascularization before the surgeries. So basically, up to now, I've discussed clinical assessment depending on the history, functional capacity assessment, and surgical risk assessment. So those three, how to categorize those who are the patients who are having very high risk of MACE. And then I've discussed about the risk assessment tool, the revised cardiac risk index, and the importance and how to calculate the risk and how to quantify the percentage, and then about the investigations and the recommendations to do the specific investigations. So then we are going to do a stepwise approach to perioperative cardiac assessment. So, for an example, if a patient with a cardiac condition coming for a non-cardiac surgery, how we should assess the patient for the surgery. So, this is basically depending on the flow charts highlighted in the American and European guidelines. So if we go for a scenario, for an example, you are doing an emergency list or the casualty list in one of the theaters, and you get a call from the surgical ward. There is a patient, 60 years old patient, who was admitted to the hospital a couple of hours ago with severe abdominal pain and found to have sepsis, peritonitis following a small bowel operation. So they have done the blood gas and found to have very high lactate. So they are suspecting bowel ischemia. So the surgeon says they want to do a laparotomy, emergency laparotomy for the resection of the gangrenous or ischemic bowel, to removal of the gangrenous ischemic bowel. So 60 years old patient. So when you go and assess the patient, maybe the patient is in the surgical ward, or else in our setup already maybe the patient is in the theater waiting area. That's what happening usually. So when you go and assess the patient, it's very difficult. Maybe it is very difficult to take the history because the patient is very unwell to give a history. Like GCS of 14, patient is drowsy, confused because the patient is septic. So you assess the parameters. So we think the patient's heart rate is around 120s, blood pressure is marginal, 90 systolic, and diastolic of 50, and saturation on room air around 93%. Likewise, those are the patient's parameters. And so the patient with his son, and you ask the son about the patient's medical history because patient is not sound mindset to give the information. So the son says he doesn't know much about the patient's medical conditions, but he says that related to his activities of daily living, he reasonably managing. So you find in a clinic book of the patient that the patient is diagnosed to have ischemic heart disease, and there's an echo which was done around 1 year back saying heart failure with ejection fraction of 45%, and patient is with type 2 diabetes, hypertension, and stage 3 CKD. So a complicated patient with lot of cardiovascular comorbidities. If you apply the least revised cardiac risk index for this patient, of course, there are more than 3 factors. Patient is having ischemic heart disease, one, heart failure, another point, diabetes. If the patient is on insulin, most of the time sepsis, deranged blood glucose, most of the time patients are on insulin, +3, and CKD +4, and then peritonitis. So they are going to do bowel resection, so opening into peritoneal cavity, high risk surgery, another factor. So more than 3 factors. Obviously, patient is having very high risk, more than 11% risk of having perioperative MACE. So what we are going to do? So the patient is having his basic investigations as well. So according to the stepwise approach, so we know patient is with high risk cardiovascular condition, scheduled for a laparotomy. So, emergency, is this an emergency surgery? Yes. A laparotomy, emergency laparotomy. So, are we going to do the surgery or not? Because we know that the patient is having very high risk, but it is an emergency surgery. If we don't do the surgery, there is a risk of patient being dying because of sepsis. So emergency surgeries we have to do, but don't forget the patients and family participation in the decision making process. This is going to be obviously this is going to be a MDT, multidisciplinary team discussion decision with the cardiologist might be involved, a surgeon, anesthetist. It's kind of maybe because of all the subspecialties could be involved, multidisciplinary decision. This patient is having very high risk, but as this is a life-saving surgery, because if we don't remove the necrosed bowel, so patient is definitely going to die from sepsis. So we have to do the surgery after explaining the risk to the patient and the family. The patient's GCS is low, around 13, 14, drowsy because of the sepsis. Patient won't understand, but we can educate the family. We can tell the family the risks, active participation of the family as well during the decision making process, and go ahead with the surgery with the acceptable explained risks. So that is how we do or how we tackle emergency situation. This is totally different from what we do during an elective procedure or elective surgery. So if we change the scenario a little bit, the same patient. So if we see in the basic investigations, when you assess the investigations, you see some ECG changes. So when you compare the previous ECG changes, which is documented in the clinic book, those are new. So if time permits, you can at the same time you can repeat the ECG and see whether there are any new changes, any dynamic changes, and then if the time permits, you can give a call to the cardiologist as well. If after discussion with the surgeons, you can give a call to the cardiologist and say that you can send the troponin as well. This patient is having dynamic ECG changes. Again, query whether this is acute coronary syndrome. Because I mentioned earlier the clinical parameters of the patient. Heart rate was around 120, marginal blood pressure, saturation on room air was 93%. So I think you can remember the type 2 mechanism. So what the factors are there for the supply demand imbalance? So patient is having very high risk of ischemia, cardiac ischemia because of this, which can be explained very well with the type 2 mechanism. If it happens to have an acute coronary syndrome, evidence of dynamic ECG changes. So, for example, so there was some time and you diagnose this patient is having acute coronary syndrome, but patient is pending emergency life-saving surgery. So, what we are going to do? So, are we going to thrombolize this patient, or are we going to give enoxaparin, or in case of STEMI? So the patient is going to undergo a major surgery. Again, kind of a thing for debate, because the patient is going to undergo a major surgery. If we give enoxaparin or thrombolysis, there is very high risk of bleeding. Again, it is multidisciplinary discussion. This patient is having very high risk, underlying cardiac wise, but the same time, patient needs emergency surgery as well. So we have to again balance the risk and take all the precautions. And most of the time, after discussing with the team and the patient's family, we most of the time go ahead with the surgery with the explained cardiac risk. If it is kind of a wound toilet or something like necrotizing fasciitis or something like that, so we tend to avoid axial or general anesthesia. We do with the regional, with the block to minimize the cardiac stress or minimize the stress response during the perioperative period. So if we go for another example, like kind of a semi-urgent surgery where there is not much of urgency or not an emergency surgery, and not an elective surgery as well. For an example, there's a 67 years old patient who was diagnosed in STEMI 5 months back. So established cardiovascular disease. One factor is there in the least revised cardiac index. type 2 diabetes on insulin and oral hypoglycemics, and hypertension on multiple antihypertensive. Again, um, uh, very high risk patient with multiple cardiovascular risk factors presented with the obstructed hernia for laparotomy. So, if we calculate again the risk with the least revised cardiac index, what are the number of factors? Non-stem ischemic heart disease, one. Diabetes on insulin, another point. And patient is going to undergo a laparotomy. Again, opening into peritoneal cavity, one of them high-risk surgeries, another 1 point. Again, more than 3 points, high-risk surgery. So more than 3 points, more than 11% risk of having major adverse cardiac events. This patient is coming for surgery. So again, going through the pathway from the beginning, again, patient is having cardiovascular factors, high risk factors. So this is not going to be an emergency surgery, but we have to discuss with the surgeon because it is obstructed hernia. Is this to be done as emergency, or do we have time? So most of the time in obstructed hernias, if there is no ischemic features or strangulation or incarceration, so we can most of the time after discussion with the surgeon, with the explainers, I think we can wait. If the surgeon says we can wait, we have some time, then we have to assess further. So, because this is not an emergency surgery, no. So then we have some time to assess whether this patient is having those very high risk conditions I have mentioned already, given whether the patient is having cardiac arrhythmia, unstable coronary syndromes, or decompensated heart failure. If the patient is having any of these, yes, then we have to again discuss whether this surgery is to be done as a semi-urgent or urgently, or whether there are any alternative things or which could be done. And obviously, if the time permits, we should treat this first before going ahead with the surgery. So, for an example, if a patient comes for a hot cholecystectomy, for an example, so we can discuss with the surgeon because of this risk factor, this patient is having this risk. So I think it should be treated first. Can we go for a interval cholecystectomy? So that is one of the options. We can treat with antibiotics and go for interval cholecystectomy. That is also again a combined decision. We have to discuss with the surgeon and see at the same time for the treatments we have to discuss with the cardiologist. Again comes a multidisciplinary team discussion. We have to decide on the optional management options. Are we going to defer the surgery? Likewise. So, for an example, if the patient is not having these, one of the very major risk categories of risk conditions, if no, and then we goes and assess whether this patient is having any of the factors where there is many of the factors which we call as risk modifiers. Further assessment of risk modifiers. So whether there are other valvular heart diseases, pulmonary hypertension. So this, if you go through the boxes separately, it's going to be very complex. If you can follow me. So if the patient is having other risk modifiers. We are going to assess the patient. We are going to dig into details whether the patient is having recent strokes, stents, any cardiac electronic devices. What is this patient's frailty score, especially in elderly patients? So we're going to assess further whether the patient is having any of these risk factors. And at the same time, we are going to assess the patient's functional capacity as well, most importantly, whether it is the MET or the Duke's Activity Status Index. We're going to assess functional capacity as well. If the patient's functional capacity is normal, if patient is not, it is categorized as low risk, and patient can undergo the surgery without further assessments. If the patient is having any of these categories, so then we have to go for further assessment, including the assessment of the ECG, in detail, and patient might need echocardiogram versus the ventricular wall. And at the same time, if the if the investigations are okay, the functional capacity is okay, then if the functional capacity is okay, then we can proceed with the surgery. Again, if the functional capacity is low, then patient might need further testing if the time permits. So, so we can do BNPs because this is basically applied to okay, according to the American guidelines. So they do practice doing BNPs all the time, but we don't have the facilities. But we can do troponin easily, and if the patient is having these um, biomarkers, high consideration these biomarkers, again, the patient is going through the pathway of additional investigations, including the stress test, and coronary angiogram. So that is when it comes to elective or a non-urgent surgery, where the permit, it is totally different from a emergency surgery. If it's an elective surgery, we have to go through the whole pathway from the top to the and then I'm going to discuss something about the guideline-based perioperative management strategies. Uh, so when it comes to general risk reduction, so after identification of the risk factors, we have to modify the risk factors, including the mostly including the dietary modifications, lifestyle modifications, regular exercises, if it is planned for an elective surgery. I'm highlighting the importance of smoking cessation here because the guidelines recommend for before coming for smoking, according to the guidelines, so it is recommended to stop smoking for more than 4 weeks. Um, the guidelines recommend to stop smoking at least for 4 weeks. But the up-to-date evidence shows if if the patient stops smoking at least for 24 hours, there are improved outcomes with that as well. So regarding coronary revascularization, so management options wise, so it could be the means of PCI, percutaneous coronary intervention, so CABG, bypass grafting. So it is recommended, especially the PCI for the patient with acute coronary syndrome with uh, STEMI, elevated myocardial infarction, so high risk in STEMI, and patients with stenosis involving significant stenosis, as I mentioned earlier, involved in the left main coronary artery. And I hope now it will be okay because I'm connected with a hotspot with my phone now. We'll see. What are the recommendations for patients with heart failure? So, there's a study highlighting in the American guidelines, study involving 38,000 patients who are with non-ischemic heart failure, ischemic heart failure, and patients with coronary artery disease without heart failure coming for non-cardiac surgeries. They have calculated the 30-day mortality, and the mortality was significantly higher in patients who has a component of heart failure. So in non-ischemic heart failure, the mortality was 9.3%, and patients with ischemic heart failure, the mortality 30-day mortality was 9.2%. And patients with coronary artery disease who are coming for the non-cardiac surgery, coronary artery disease patients without a heart failure component, the mortality rate was around 2.9%. So that means the patients with the component of heart failure had a threefold greater risk of developing uh, the adverse events. So when you come across a patient um, with the component of heart failure, that means those patients are at a very high risk of developing dismays, and you have to take extra precautions or extra cautions during the perioperative management in a patient with heart failure. So again, they highlighted the importance of stopping these SGLT2 inhibitors. That is one of the drugs, especially in the developed countries, they use commonly uh, for the treatment of diabetes. And in our setup, we also see these drugs, SGLT, sodium-dependent glucose transporter 2 inhibitors. The examples are glyphosate, empagliflozin, dapagliflozin like drugs. So we have to withhold or stop the drugs 3 to 4 days prior to surgery, because these drugs are having very high risk of developing these patients who are on these drugs are having higher risk of going into euglycemic ketoacidosis. These drugs are may basically used for the treatment of diabetes, but because of their beneficial cardiovascular properties, they are used for the heart failure patients as well. And then blood pressure management. So in the guidelines, it is recommended that it is reasonable to continue the medical therapy for the high blood pressure during the perioperative period. And patients with the risk factors for perioperative complications with poorly controlled hypertension, like systolic blood pressure more than 180 and the diastolic blood pressure more than 110, uh, the surgery it is reasonable, it is rational to defer the surgery if the blood pressures are very high above this reference range. And they advise the importance of maintaining intraoperative and postoperative blood pressure, systolic blood pressure of more than 90, and a mean arterial pressure of 60 to 65. Having said that, however, so some patients, especially patients with cardiovascular conditions as well as CKD, sometimes CKD patients are very used to high blood pressures. So their organ perfusions are used to high blood pressures. And in those patients, reduction of the systolic blood pressure is to 90, even though the guideline says that we have to apply the guidelines for our individual patient depending on the individual patient's characteristics. If they are used to very high blood pressures, so dropping the blood pressure, systolic blood pressure to 90 would not be appropriate for that particular patient. So reduction of we have to be careful if the blood pressure is, if there is any blood pressure reduction more than 20% from the baseline. And they advise to start the medications the patient is previously on when it is feasible as early as possible during the post-operative period. And regarding the stroke, patients with a history of stroke, previous stroke or transient ischemic attack (TIA), so it is advisable to, it is reasonable to delay the routine surgery for more than 3 months from the incident to minimize the risk of or reduce the recurrence of stroke or the MACE during the perioperative period. This is after a stroke. And then pharmacological wise, what are the other risk reduction strategies? If a patient is on a beta blocker perioperatively, so in a patient who are taking beta blockers, if a patient is established on a beta blocker, it is advised to continue the routine beta blocker medication during the perioperative period. If you are interested, if you go through the Coaisl 2 trial, you can see if the it is not recommended to abruptly start or withhold the beta blocker who are established on therapy during the perioperative period. If there is any medical reason where beta blocker is essential to be introduced during the perioperative, before surgery or perioperative period, it is always advisable to start the beta blocker at least 7 days prior to the surgery to minimize the complications and minimize the mortality. It is in the studies it has found out if we start abrupt start of beta blocker during the perioperative period, it increases the mortality. The patient is taking statins, again we can continue throughout the perioperative period. And regarding enalapril, the RAS, renin-angiotensin converting enzyme inhibitors, uh, if the RAS inhibitors are started because of the heart failure, for the management of heart failure, it is advised to continue the RAS inhibitor during the perioperative period. But if it is started to treat hypertension, they recommend it to be stopped 24 hours prior to the surgery. Again, it is individual dependent, depending on the patient blood pressure. So we can modify. Although the guidelines recommends that, so we have to apply to our individual patient, depending on the patient's blood pressure. We can decide on omission or continuation of the medication. Then the SGLT2 inhibitors, the glyphosines, I have discussed already. And angiotensin converting enzyme inhibitors, if it is, I've discussed, if it is for heart failure, it is reasonable to continue. If it is for hypertension management, then we can stop 24 hours prior. But again, we have to think of the patient's baseline blood pressures as well. So what are the recommendations related to antiplatelets and oral anticoagulants? So again, the management of perioperative antiplatelet therapy is kind of a multidisciplinary discussion because of if we stop the antiplatelets, there is very risk of thrombosis. If we continue, there is risk of bleeding. And to continue if it is dual antiplatelet therapy, if we continue the therapy, so by delaying surgery, then there will be consequences of delaying the surgery. So again, it is multidisciplinary discussion regarding the management of perioperative antiplatelet therapy. So especially in patients with prior PCI and all the cardiac conditions as well, we try to at least continue aspirin to minimize these adverse events. And similarly, for the patients with cardiovascular disease who are receiving oral anticoagulants, especially patients with chronic KF, because of the thromboembolic complications, risk of thromboembolic complications, patients are on oral anticoagulants like warfarin and other liver anticoagulants as well. For an example, apixaban, rivaroxaban, dabigatran, like drugs. So the oral anticoagulants again comes to multidisciplinary approach of interruption therapy. So we have to balance the risk of thromboembolism and the risk of bleeding. Most of the time, the patients are on oral anticoagulants. Before a surgery, we are going to admit the patients a couple of days prior, and we are going to stop, and we're going to introduce with the hematologist opinion or help as well. We're going to bridge the therapy with the heparin or enoxaparin during the perioperative period. And regarding the antiplatelet therapy discontinuation, again, we have to take the cardiology opinion prior to that. So if you go through a chart, so optimal timing. So if it is an acute coronary syndrome, it is always advisable following an acute coronary syndrome to continue the dual antiplatelet therapy for 12 months. And again, if it is to be stopped because of a surgery, so we have to balance the risk and benefits. We have to again get the cardiologist's opinion regarding stopping the dual antiplatelet therapy. Sometimes we tend to give only aspirin, and sometimes after discussion, if there is a very high risk in some patients, we can see the patients are on monotherapy only with clopidogrel. It depends again depends on the cardiologist's opinion regarding after assessment of the patient's risk factors. So if we get a balloon angioplasty, so without any stents, if only the balloon angioplasty is done, we have to continue the dual antiplatelets for 14 days. So we have to delay the non-cardiac surgery for 14 days. If in case of PCI, if it is a bare metal stent, so delay the surgery for 30 days. So so you can remember this, or we can refer to charts. So if when you are assessing a patient during your pre-operative assessment, if a patient has like kind of patient is on dual antiplatelets. Yeah. So we have to see why the patient is on dual antiplatelets. What is the reason, and for how long patient has been taking the dual antiplatelets. That is very important to assess when you are assessing the patients. When you are assessing the patient during your pre-op assessment. So if it is a drug-eluting stent in PCI, because I've already told that nowadays, because of the durability of stents, they're going to go for or selectively go for drug-eluting stents. In that case, if the drug-eluting stent was placed because of acute coronary syndrome like STEMI, following STEMI, so if it is a routine surgery, we have to delay the surgery for 12 months. And if it is a time-sensitive cancer surgery type of, then we have to delay the surgery at least for 3 months. And their recommendation, if it is a drug-eluting stent in place following acute coronary syndrome, if it is less than 1 month, do not perform non-cardiac surgery during less than 1 month period, because if you stop the dual antiplatelets, where there is very high risk of stent thrombosis and major cardiovascular events. If the stent is placed because of chronic cardiac disease, not an acute condition, because of chronic cardiac disease, then non-cardiac surgery should be delayed for more than 6 months. Again, the time-sensitive surgeries like cancer surgeries for 3 months, and again advisable to not to do non-cardiac surgeries because of the harm if it is less than 1 month duration. So those things you have to keep in mind. So I'm highlighting again, when it comes to stents and all, you have to see what is the type of stent the patient is having, bare metal stent or a drug-eluting stent, and how long the patient, when the stent was placed, and how long the patient has been taking the dual antiplatelet medications. That is important to decide on when to perform the surgery depending on the urgency of the surgery. And regarding the blood glucose management, what are the recommendations? I've already discussed the SGLT2 inhibitors, glyphosines. So that is used for treatment of diabetes. So they advise to continue these medications for 3 to 4 days because of the risk of metabolic acidosis. Most of the time tend to have euglycemic ketoacidosis if we continue the drug during the perioperative period. And in patients with diabetes who are on metformin, they advise to continue the metformin during the perioperative period. And within 3 months of the surgery, it is advisable to do an HbA1c and optimize the blood glucose depending on the HbA1c levels. And more importantly, what is the target blood sugar to be maintained in a patient with cardiac disease during the perioperative period? There were different studies. So first one was Vandenberg study, if you're interested. So there they tried with the tight glycemic control. They tried to keep the blood glucose in cardiac surgical patients from 80 to 110. Where they have found out the mortality was very high with the tight glycemic control. But after that, there was nice sugar trial and the guidelines. So after that, the recommendation in the cardiac patients who are coming for these non-cardiac surgeries and all, to maintain the blood glucose around 140 to 180, 140 to 180 during the perioperative period to have a better outcome and to minimize the complications associated with hypo or hyperglycemia. So remember, 140 to 180 is the reverse recommendation. And then about the anemia management in patients with non-cardiac surgeries, So who are expected to have high blood loss, a very high blood loss during the surgery. So and it is advisable to use tranexamic acids to minimize the risk of blood transfusions and minimize the blood loss as well. And in patients who are having during the assessments, and in patients who are having iron deficiency anemia, because of the complications associated with the blood loss, blood transfusions, so iron therapy is advocated. So as we all know, if you start iron therapy, it takes at least 7 to 14 days for the action. So if it is kind of a routine surgery, then of course we have time. We can start iron therapy to treat iron deficiency anemia. We can start at least 2 weeks prior. And if it is urgent, so we have to accept the risk and go ahead with the blood transfusion if the hemoglobin is very low. And again, what is the target of hemoglobin? We have to maintain in cardiac patients. So when it comes to hemoglobin target, so or earlier it was advised in the cardiac patients to have a hemoglobin of at least 10, the target of 10 grams per deciliter of hemoglobin, especially prior to surgeries, at least of 10. So, in the recent guidelines, it is highlighted that the recent studies have failed to find out any benefit and any additional benefit of maintaining this target hemoglobin of 10 instead of 8. So, so we can maintain 10 or 8 depending on the patient's conditions. Or even though the study says that 8 is not having any additional harm, maintaining a target of hemoglobin of 8 in cardiovascular patients. But if the surgery is going to be a very high risk surgery for bleeding, of course, it is reasonable to top up the hemoglobin up to at least 10, I think. So again, although the guidelines are study evidences are there, so we have to apply to our individual setup if there's high risk of bleeding. So it is reasonable to keep hemoglobin somewhat higher. And so this is going to be my last slide. So valvular heart diseases, especially in the patients with symptomatic valvular heart disease, symptomatic severe aortic stenosis, mitral stenosis, symptomatic severe valvular regurgitations, those patients should undergo some sort of valvular interventions therapeutically before undergoing elective non-cardiac surgeries. So it could be percutaneous interventions, mitral valve commissuratomies, for an example, or it could be valve repairs or valve replacements before non-cardiac surgery. It should be done before elective surgeries in patients with severe valvular disease who are symptomatic. And of course, echocardiography is recommended in patients with suspected valvular lesions where you find significant murmurs during your assessment. And in moderate to severe valvular disease, in these three facts, it highlights in moderate to severe valvular disease, if the patient is asymptomatic with normal left ventricular functions, so we can go perform the surgeries with low risk. But of course, we should have a plan B in case if there are complications develops. So we should be prepared to take actions or to manage the complications appropriately. So we should have a plan B. Plan B if we are going ahead with the moderate to severe valvular disease with normal systolic functions as well. So those are the things I wanted to highlight. Uh, Extremely sorry there were some interruptions because of the signal issues. I think because of the weather in Norelia. So thank you. Those are the things I wanted to discuss, and I'm happy to answer if there are any questions if time permits.